Sound perfect.
So what I'm going to do is talk, I don't really have any disclosures related to an infection talk. This is our PJI center that we started about 6 months ago. And interestingly enough, we've performed over 200 procedures since last fall related to arthroplasty infection. We also have a website for patients and their families, healingjoints.org. So if you have a patient there, there's some tips about how to manage not only the physical, but the psychological and the caregiving aspects of dealing with a two-stage or so periprosthetic joint infection. So what we're going to talk about is an evidence-based approach to management and treatment. We're going to talk about some diagnostic tests, the role of irrigation debridement, the role of one-stage and two-stage, and I'm going to give you my biased 2020 treatment algorithm. This is the first infection case I saw in practice. It was over 30 years ago. Interesting problem. They didn't have wound vacs back then. This was wet to dries to see. So it's a problem for patient and surgeons alike. We all know about the certain risk factors: obesity, malnutrition, concurrent infection. Optimization is a buzzword now, and we have a pretty robust optimization program at our shop. We don't operate on people who smoke, have A1Cs greater than 8, if their BMI is greater than 40, or nutritional problems. You need to avoid intra-articular steroid injection within 3 months of surgery. That's some new data that came out a few years ago. Controversies on some of this stuff for antibiotic cement. What's the best irrigation solution? And, so let's talk about a preoperative evaluation. And you've got to be able to distinguish between septic and aseptic loosening. Radiographs are very important. We all have that at our disposal. But history and physical is probably the most important and most cost-effective diagnostic tool. And a careful history can raise flags which make the diagnosis relatively easy. I quiz all my patients who come in with a painful joint. You know, did you have a wound healing problem? Did you have to take antibiotics after surgery? Did you have prolonged drainage, cellulitis? And very important, lack of a pain-free interval. If someone's never had pain relief following arthroplasty, that should raise some red flags for you. Radiographically, if you see something like this in the first 2 years, you may not even need to aspirate it. That thing's infected. So if in the first 2 years you have loosening, you need to be highly suspicious for a PJI. We're all familiar with these basic serology tests. CRP should normalize 2 or 3 weeks post-op, SED rate greater than 30. And if they're both normal, chance of infection is rare. So what about some other tests? Bo Mason and I looked this up about over 20 years ago. It's been redone 10 times over, but the results are still the same. If you have, greater than 2,500 white cells and a fair percentage of PMNs, your sensitivity and specificity are quite high. And I really lean on cell count for my evaluation. The old 50,000 was infected. That's for a native joint, not a prosthetic joint. And that was the thrust of this first article on this subject. Here's the MSIS infection criteria that I use. A sinus communicating with the prosthesis, or 2 positive cultures, or 3 of the 5 of these criteria. None of these are alone are diagnostic, but you need to take them kind of as a whole. Greater than 5 neutrophils and 5 high power fields is also important. So let's talk about intraoperative assessment. We've got 3 things at our disposal: cell count frozen and leukocyte esterase. Leukocyte esterase is the dipstick we all used for urinary tract infections. It's gone into the joint world. Problem is, it isn't very sensitive. Okay, it's an aid to rule out infection. Bloody aspirate invalidates the test, and you really can't use it as an independent screening tool. Alpha defensin is one of the new kids on the block. It's an immunoassay that measures the concentration of a peptide in the synovial fluid. The neutrophils secrete the specific protein in the face of infection. So it's released from the neutrophils, attacking pathogens, trying to kill something. Problem with it, there's occasional false positives and occasional false negatives, so you have to be careful about that. But if you combine it with the synovial CRP, right, it's quite accurate. So don't just look at the alpha defensin positive or negative. You got to go down on the sheet and look at the synovial CRP. So if I've got an alpha defensive positive and the synovial CRP is 1, that doesn't help me very much. If the synovial CRP is 10, that's very helpful. This has been independently evaluated. It was put out by a commercial author, and it's been validated in a few different studies, and this is one of them from Germany. What about molecular diagnostics? That's the real new kid on the block. Next generation sequencing. It identifies bacteria through amplification of ribosomal RNA. And then I've got this huge database of bacterial species. Here's the problem. Every time I send one of these in, I get like 10 positives, some of which I've never heard of. So it's a little too sensitive. You know, are they true positives? Are they false positives? Are they fragments of non-viable bacteria? Or are they part of an intra-articular microbiome that's similar to what we find in the GI tract? This is an interesting article talking about it. Next-gen sequencing identified microbes in 25% of uninfected joints and 36% of primary joints. So it begs the question, do we have a normal microbiome in our synovial fluid? So this really hampers its use, at least in my practice. I've never seen a negative one. Okay, if we look at, this was just one of my fellows just presented this at our national meeting last year. False positive rate, 19%, false negative rate, 35%. So I don't think this is quite ready for prime time yet. You can't rely on this, certainly not in isolation. I use it occasionally in a very difficult case where I've got conflicting data. This is another one, same kind of thing, 25% in aseptic revision, another study, 35% in just normal synovial fluid. So this slide's about 25 years old, and it still holds. There's no single test you can consistently predict for infection. You've got to take this as a grouping and make a clinical decision. You know, over-reliance on one aspect of this really should be avoided. Your judgment plays into this a lot. We'd all like to have a silver bullet. Unfortunately, it just doesn't exist. Let's move on to treatment. I'm going to talk about 3 different areas, most of which are all controversial. So we'll go through, try to make this evidence-based for you and go over some of the articles. IND is a time-honored procedure for orthopedic infections. In 2002, somebody looked at the data and they found a 68% failure rate of INDs. About 10 years ago, I reviewed all the literature, looked at 2,000 patients, 41 articles, 60% failure rate. So a fairly consistent failure rate for irrigation, debridement, and prosthetic joint infection. So why does a procedure that fails 2/3 of the time continue to be frequently utilized? And we've all got a lot of emotional investment by the patient and the surgeon, and the alternative of removal is perceived as radical. And attempts to save the implants, you know, they're well-intentioned. Problem is it fails 2/3 of the time. So there's a true patient. This is about 10 years ago. And I'd done an IND on this guy, and he said, well, what's the success rate of that? And I said, well, the success rate's about 30–40%. And he says, what if you took it out and you started over? And I said, well, the success rate's about 85 or 90%. He said, what'd you do that to me for? And I had a hard time answering that question. So I said, we need to figure this stuff out. So what we knew in 2010 is it doesn't work in chronic infections. The overall failure rate of IND is high. We all have anecdotal reports of success, right? And we all want this operation to succeed. Problem is it doesn't. It doesn't work sometimes. So we had, at that time, we said, okay, there's 3 questions I need to answer. Does the organism matter? At the time, people were saying streps are easy to eradicate versus staph or resistant organisms. Does the timing of IND matter? What's the efficacy if it's done quickly, if you get to them right away in the perioperative period? And what happens if an IND fails? Does it make your 2-stage results worse? So I'll go through some of the things, how we tried to answer that about 10 years ago. So this is a group of guys I put together. We said, does the organism matter? Dr. Odom helped with this one. She was actually the lead author. I looked at 184 INDs across the country at about 8 different sites. We had a final data set of 136. And what we found is that strep, we don't do any better with strep than we do with other organisms. 71% failure rate, 67 with other organisms. So we concluded that the eradication rates for strep are comparable to other causative organisms. How do we do at MRSA? Well, we didn't do very well. This is a combo study with the Mayo Clinic. We had an 84% failure rate in resistant organisms. That's really not a good idea if you're dealing with a resistant organism. In contrast, there are people from this state saying you couldn't do a two-stage reimplantation with Mrsa. Once again, we combined with Mayo on this study. We had an 86% success rate in eradicating Mrsa. So that's a good option for a Mrsa. Second question, does the timing of irrigation and debridement matter? What's the efficacy if we do it in the perioperative period, within 90 days of surgery? Now, this was a publication in Core in 13 on this. We had 95 patients within 3 months of the index surgery, lost a few to follow up. So there comes that number again. 84 patients underwent IND within 3 months and 64% failed. We got to them a little quicker, 58% failed. Okay. And if we got to them with 10 days, that was our worst results. So once again, irrigation debridement, not such a great operation. And we did a regression analysis on that. Really were no covariates that helped us. So here was a real controversial paper. What happens if IND fails? And what's the fate of two-stage reimplantation after a failed IND? We won a little award for this. I'll go through. So we want to determine whether the outcome of patients failing, did it affect their two-stage results? Because it's my feeling that if someone sits around for a year, 18 months after an IND, that bacteria is going to be significantly entrenched in their bone and soft tissue, and it may make things harder to eradicate down the road. So we had 192 patients, and our recurrence rate was 30%, and success 70%, which was kind of below what you'd expect from a two-stage reimplantation. So we concluded that, they have a failure rate of 30%. You may be burning some bridges just doing an IND. So why does an IND work? Well, virility of the organism, certainly we showed you that with Mrsa. But it's the inability of the parental antibiotics to penetrate the glycocalyx biofilm layer. I'm going to show you that was by Gristina at Wake Forest in 1986. He published that right when I started practice. So here's how they work. Bacteria attaches to the implant right away. They secrete a dome, a protective matrix that protects the bacteria for external threats such as antibiotics or your immune system. And every once in a while, they shed this free planktonic bacteria. I think of it as the dome opening up and just poof, out comes the bacteria. And that's why I think we see some of these, quote, acute hematogenous infections where we don't really see a source. And antibiotics can only kill free planktonic bacteria. They can't get into the dome. They can't penetrate. And this is kind of a schematic of it. You can see them attaching to the implant. They put up the dome. Every once in a while, the dome secretes this planktonic bacteria. So how fast does this happen? Okay, the rate at which these form may affect the success rate. So can we intervene before biofilm becomes firmly attached? I showed you some data a minute ago, said maybe not, as our worst results were the closest to the time of surgery. They attach within minutes. They form microcolonies within 2 to 4 hours. Then the dome goes up in 6 to 12 hours. And they become mature in 2 to 4 days. So, tough to get them quick enough. And they can lie dormant for years. We have symptomatic patients who have elevated serology at negative cultures. Cultures can only detect the free planktonic bacteria. And if that biofilm eventually weakens and releases, I think that's where we might be getting our hematogenous infection. It's not the infection in their toe or an abscess in their mouth. It might be that just the dome opened up and out comes the planktonic bacteria. So Niall's question on this, is it seeding from a remote source or an indolent biofilm infection? Okay, what about, this is talking about, does the host matter? So this is a recent article out of Mayo, and they classified the hosts, and they had good success in type A hosts and similar poor results in type C hosts. And I think that's pretty much normal. Most of the people we see are B and C hosts. Here's another study, a more recent article than what I published. 206 patients, long-term failure rate, pretty close to 60% again. 5-year mortality, interestingly enough, was 20%. So high mortality rate in these sick patients. So I kept talking about 60% failure rate. Here's one of the first papers I wrote, 1991. We looked at 33 cases from Charlotte. There's that number again, failure rate, 61%. So it's pretty, we haven't moved the needle much on irrigation and debridement. So we got to do better. Okay, and here's one way to do better. This is Mayo Scottsdale, just came out this past year, 83 patients, follow-up 42 months. Overall success rate, 86%, dramatically different from that 60% failure rate I've been talking about all morning. So right now I'm considering double debridement as the new standard of care for my patients. There were some small studies years ago and I've used it intermittently, but 86% after what I just told you, that's tough to ignore. So can we make it any better without subjecting patients to 2 operations? So this is a study that came out, they won an award about 2 years ago about intraosseous antibiotics. And if you use intraosseous antibiotics, let's say in the tibia where you put it in through the bone, 10 to 20 times higher concentration rate in soft tissue and bone. That's dramatic. Far above what you can reach with IV antibiotics without the kidney risk. So I thought, can we improve our results of IND, which are modest at best, by using adjuvant intraosseous antibiotics? So AUKUS is sponsoring a study. I'm the lead-in. We've got 3 arms, standard IND with polyswap that we do all the time, a single-stage IND with intraosseous antibiotics, and finally a 3rd arm with double debridement with intraosseous antibiotics. We've done a pilot of 35 cases that we're going to submit for the abstract cycle this year. Our success rate in primaries at 1-year follow-up is around 80% using IO antibiotics. And we've used it in some chronic unresectables, and that was a 44% success rate. So very early study, okay? So we've got to do better, and I'll let you know about that. Let's go on to 2-stage reimplantation. That's pretty much the gold standard. You remove the infected arthroplasty, you put in some type of antibiotic spacer, and you give them 6 weeks antibiotics. These are the spacers we used to use. You know, these hockey pucks used to stick in there. Prevented soft tissue contracture. Patients were a little more comfortable. The problem is they don't work very well if you just do the hockey pucks. You'll get bone loss. We use cross-rush rods or tibial nails or something to reinforce and keep the legs stable. This was something that Bo and I came up with years ago. A temporary molded antibiotic spacer would allow range of motion between stages. Right now, there's pre-mades off the shelf. You can get them. They're expensive. They're difficult to customize. The molded one, we can put whatever antibiotic and how much we put in. People don't like to bend their knee much with this. A lot of crepitation with this. And we've kind of morphed into a conventional femur and an all-poly tibia with IM antibiotic dowels. We can put as much antibiotic we want to, and it's an improved range of motion. Patient's very comfortable. That's what I had a couple of years ago when I had this issue. So here's a typical case, long stem revision. That's the mold we use now, the spacer in the middle, and then the reconstruction on the right. The advantage of doing mobile spacers, if you've ever taken down a static spacer, that's a real grunt just getting everything exposed. And mobile spacer not only helps the patient, but helps the surgeon when he goes to replant it. We did a little study on this, won an award comparing articulating versus static spacers. Something just came out in JBJS this week about a prospective study. Came to the same conclusion that the reinfection rate's similar, the bone loss is less, and exposure was easier. We also showed a year or 2 later that the functional results were a little better with articulating spacers versus static spacers. So that's become the standard of care now. How about the hip side? This is what we use traditionally, non-articulating spacers. However, exposure is tough on this. It's hard to get people out to length. And they're unstable. So once you take everything down and do that big exposure, these people like to dislocate their hips. Now, this was published in '07. It was reporting results of the era before big heads, and but results were pretty dismal. So we morphed to an articulating prostalax system. Patients are more comfortable, diminished instability after reconstruction. But you got to do them right, and you got to use the right articulating spacer used to avoid stuff like this. I'm not a fan of these hemiarthroplasty off-the-shelf implants. This is the X-ray on the right is what we currently use. That's a constrained implant with a prostalac on the right side. So let's talk about one stages. One stage versus two stage, what's best? It's a subject that I needed an answer for my whole career. You hear out of Europe that they do one stages in Germany and everybody does great. Problem is they don't publish anything, and their follow-up when they do is very short. So there's conflicting data on this, and I'm going to take you through some of that. I think if we're making big decisions, you got to have big data. So here's a meta-analysis of 1,800 patients from 4 different continents. They found that the reinfection rate in the 2-stage was much higher than the 1-stage. So that was surprising. Here's something that says the opposite. 16,000 patients from 2005 to 11. The 2-stage had a 19% failure at 1 year, 1-stage 25%. A little worse with the 1-stage at 6 years. Okay. Here's the decision tree analytics. Very complicated thing was presented at ACUS last year. In terms of quality of life, 1 stage is best. Here's a series out of the editor of the British Bone and Joint Journal. 100% success rate with 1 stage. The problem is he didn't do any sick people. He was cherry picking. You know, he excluded resistant organisms, the sinus tracts, vascular disease, or anybody with a significant comorbidity. So that's something you got to take into account. Let's look at some systematic reviews. 1,100 studies. They concluded that overall quality of studies was poor. Another systematic review, 10 one-stage studies is all. They compared it to 108. So you can see the bias there because the limited number of one-stage studies. Need to investigate this further. And a final systematic review. They just don't have enough one-stage studies to make a systematic review really mean anything. And they felt that the evidence for both was largely of low quality. Another systematic review. There's just no randomized control trials that have been published. Little high quality evidence addressing that issue. So the 1-stage data is encouraging. It's difficult to interpret due to limited numbers, organism exclusion, and comorbid patient exclusion. 2-stage is the gold standard, but we're doing closer to 80% success than 90%, which is often quoted. So I felt we needed to look at this. So a few years ago, I got an ORAF grant to study this. There were 5 initial sites, many of which did not enroll anybody for a few years. So I added many of my former fellows and friends who are actually doing the work. And so we've got 15 sites now. Our inclusion criteria has to be primary surgery. We got to know the organism so we know what antibiotic to put in the cement. We're doing all comers except for fungal and immunosuppressed HIV patients or people we can't close the wound. So very different than that 100% success rate out of London. We re-prep, we re-drape. These take forever. We need 308 patients for our power numbers to show a 10% difference. And we're almost done with it. We've got 260 pre-COVID, the 308 we need, but I can't tell you the results. So here's how we do it. We have 1 table for extraction and 1 table for implantation. The clean side is set up and stuck in the corner with drapes over it. The dirty side is wheeled out of the room during cleaning. And after extraction, the wound is whip stitched. We put a sterile towel over it, an eye band. And the dirty drapes are taken down and dirty instruments rolled out. Nurses love this stuff. They actually hate it. The room is cleaned, followed by re-prepping and draping. And we uncover the instruments. So what goes on the dirty side? We do everything on the dirty side. We do all our bone prep, we debride, we irrigate, we do our trials. We have a very complicated irrigation thing with dilute betadine, peroxide. The only thing that goes on the clean side, once you get to the clean side, you're just banging on the implants or cementing them on. And so all we need is our final component assembly tools. This is our irrigation process. I did steal that from the London group. We use hydrogen peroxide, leave that for a 2-minute soak, another 3 liters, then dilute betadine, another 3 liters. So 9 liters of normal saline, betadine, and peroxide. Okay, and then just before we put things in, we do it all over again on the clean side with just a liter in between each. I don't know what powdered vancomycin does, but I was scared to death when I started this study, so I wanted a belt and suspenders approach, so we use Gramavanc throughout the wound. Not sure it matters, no data on it. Then everybody gets 6 weeks of IV antibiotics and 6 months of PO antibiotics. So finally, I'll close and go through my own personal protocol as I sit here. Irrigation debridement for PJI, I do it a lot less frequently than I did early in my career. If I do debride and they're not in the IO study, I do it twice. It's reserved for acute hematogenous infection with symptoms less than 3 weeks. And you've really got to interrogate people to make sure they weren't symptomatic, you know, for 3 months or 6 months. If they've been pain-free and all of a sudden it comes up, I think you can do an IND then. And then there's certain people, if they're elderly, they're infirmed, and they've got implants like this. We just sent something in for publication on extremely difficult to extract implants where we did just INDs rather than the extractions. And in terms of function, those people we did INDs on did good, but did much better. But you can't call a unicondylar arthroplasty irresectable, so some judgment here. Perioperative infection of the hip, I'm going to do a 1-stage if they're cementless and easily extractable. What you don't want to do is do an IND, wait till it ingrows, and then you've got to do a big whack to take it out later with a lot of bone destruction. Acute perioperative infection of the knee, that's a problem because most of them are cemented in. If they're cemented in, I'll do a double debridement for the Mayo Scottsdale protocol, 6 weeks of IVs, and then chronic suppression. There is some data now that's come out say chronic suppression does better than non-chronic suppression. And if they're cementless total knees, I'm going to take them out and do a 1-stage protocol. Acute hematogenous infection, I told you before, I'm not sure it exists. It might be the dome just opening up planktonic bacteria, but the length of symptoms, you really got to interrogate them to determine whether it's an indolent biofilm or seeding from a remote source. So if I do the 2-stage, we leave beads for 5 to 7 days. That's part of the Scottsdale protocol, and you bring them back to the OR, take out the beads, put in a new poly, 6 weeks of IVs, and chronically suppress. If they're not in the study, they get a 2-stage. If they are in the study, they get a chance to have a 1-stage or a 2-stage. So your SED rate and CRP don't need to normalize before you replant. That rarely happens, actually. And there really is nothing to guide you right now beyond a negative aspirate and a dropping SED rate and CRP to tell you when it's safe to reimplant. So 1-stage versus 2-stage studies. Here's the two studies that are out there, 70 patients from the Endo Clinic in Germany with limited follow-up and 39 patients from London. We're almost at 260, so I think we're going to blow them out of the water on this one. So 1-stage versus 2-stage. Wish I could get this to run. Well, this is kind of some of the stuff we see. I'll let you know. So I'll open that up to questions or however you want to do it, Josh. Hopefully we've got a little time left.
Yeah, again, this is one of our limitations. It's a fantastic lecture. Tom, really appreciate it. Certainly open to conversation and discussion. If anybody has a comment or question, just unmute yourself. Unfortunately, there's not a great way for us to call people out in order. So just anyone have any comments?
Tom, that was a great presentation, Joe Shu. One of my questions was around the uncemented. Having gone in to Rithington, where apparently everything needs to be cemented on both sides, it looks like if you're having an infection, if the one stage proves to be as good or better than a two stage for infection, would that push you think some joint surgeons to do more cementless, especially for things like around knees, where cementing seems to be more common?
Yeah, in terms of treatment, and if you're going to go to a one stage, a cementless, that's like a piece of cake compared to a cemented knee, taking it off. And so I think we're gonna start to morph as the porous metals get better. I think we're going to morph over the next few years into some cementless things, but we've got to do a study in that. We've got a prospective randomized one that we're starting here at Ortho Carolina on that subject. But you know, early in the days, Joe, I wrote a paper saying that you should go back after taking out a cemented hip with a cementless revision implant. And it was met with, it took me about 5 years to get that published. You know, we're using cementless revision hips to revise cemented hips, right? But they felt that if you didn't have the antibiotics in the cement, you couldn't cure the infection. And of course, we don't use cemented revision hips anymore. And that worked okay. But yeah, that was fought on the editorial side for 5 years before I got it into literature. So I hope that answers some of that.
Tom, this is sort of a socio-political question, but when I was in Durham, Bolo and the team were getting hammered so badly by infections, and we're losing so much on the financial side and all by taking care of these patients that they actually stopped taking them. Whereas we have kind of an open arms approach, which is so very commendable. But how do you make the economics work on this? It's obviously a challenge to manage these two-stage procedures and revision cases and whatnot that come out of this infection world. How does that work from a practical standpoint?
Well, I can tell you how it works for the surgeon. We published this a year or two ago. Keith, my son, was the lead on this, and we determined the hourly rate for doing a primary arthroplasty and compared it to a resection or a two-stage, and the reimbursement to the surgeon is 1/3 per hour of what you get for doing a primary. So this is a labor of love. I didn't get in the revision business to get rich, but there's a real need for it, and it's an obligation as a tertiary center that we've developed, and we've actually, like you said, we put our arms around it. We established the Ortho Carolina Periprosthetic Joint Infection Center, and they're coming at us like gangbusters, and that's fine. We need to be in a position to answer all these questions. You know, from my talk, you can see we don't have all the answers, but if we do a large volume of infection work, we become better at it, and we start to answer some of the questions like one stage versus two stage and IO, and develop protocols that'll help people around the world. So that's our obligation. We're not going to play dodgeball with infections. It's just a philosophical thing for us.
All right. Well, Tom, I guess we'll let you get off to the operating room. Really appreciate you kicking us off here for our virtual Grand Round series. We'll look forward to hopefully the near future where we're all back in the same room sharing clean air. And would ask all the residents who are on to make sure that you sign off of this Zoom call for for residents conference. There's a separate Zoom meeting for that to follow this. So go ahead and log off this and sign on, and we'll get going in a few minutes with Dr. Scannell. So thank you, Tom, and everyone else who's online today. Again, the color of the day for CME is green, and we will look forward to seeing everyone next week when we're going to have Dom Fehring from CNSA talking about disc arthroplasty. Thanks, everybody.
Okay.
Thanks, Tom.
All right. Thank you all for having me.